So good afternoon, everyone. And on behalf of OGP, I take this opportunity to welcome you all to our first meeting, and thank you all for being here. So my mandate over the next 10 to 12 minutes is to talk a little bit about redefining the management of HER2-negative early breast cancer. We're going to look at a little bit of the background. So breast cancer is the most common one. We know that over a third of patients will recur despite treatment, and about 5 to 9% with HER2-negative disease will have a germline BRCA mutation. And there is a nice algorithm for the management of HER2-negative disease. Where tumors are small, we opt for surgery first, but where they are advanced, we prefer, or where they are larger and node positive, we prefer neoadjuvant strategies, and these are usually in the form of chemotherapy, and of course, tailor-made decisions to handle the residual disease that is remaining. There's been a vast changing landscape in HER2-negative early breast cancer management. We've had several trials which have looked at escalation of therapies, mainly targeting residual disease, and most of these trials have been positive for event-free survival. We also recognize that germline BRCA mutated HER2-negative breast cancer is a unique disease, and we can target this with PARP inhibitors. So how is BRCA mutated disease different? These patients have more aggressive disease. They are diagnosed at a younger age. They are of a higher grade. A lot of them develop central nervous system metastasis, and they more commonly are at risk for contralateral and ipsilateral tumor recurrences. So we have some retrospective data from India, and these are small numbers. It's not been studied in a prospective fashion, but we know that the prevalence of mutations seems to be higher than the Western population. And in some smaller studies, BRCA mutations were identified in almost 13 to 15% of patients. As we speak, we are now embarking on a multicentric study in all comers with breast cancer to look at the actual prevalence of BRCA mutations in this population. It is important in the early breast cancer setting to have upfront knowledge about BRCA status. This may influence our surgical choices, whether to go in for a bilateral prophylactic ipsilateral surgery plus a prophylactic mastectomy on the other side, and whether to do an oophorectomy in the same sitting. So it's useful to have this information up front. And preoperative testing may also impact our decision-making and help us to have a better multidisciplinary approach. So looking at the Olympias trial, this was a phase 3 study of olaparib, a PARP inhibitor versus placebo, in high-risk patients in the adjuvant setting. So we had patients with stage 2 and 3 breast cancer who were HER2 negative. They have had to at least completed 6 cycles of adjuvant chemotherapy and harbor a germline BRCA1 or BRCA2 mutation. The risk groups were 4. In the neoadjuvant, you had to have a non-PCR in the triple negative group, and in the HR positive group, you had to have a non-PCR and a CPS-EG score of more than or equal to 3. In the adjuvant group, it was triple negatives more than 2 centimeters or node positive, and in those with HR positive, they had to have more than or equal to 4 positive nodes. Over 1,800 women were randomized to placebo versus olaparib, and this was a double-blinded study. The primary endpoint was invasive disease-free survival, and distant disease-free survival, overall survival, and health-related QOL were secondary endpoints. So I've already described the high-risk criteria. It's important to know that 82% were triple negative in this study, and 18% were HR positive. And CPS-EG is something we should be discussing with our pathologists. It includes the clinical state, the pathological stage, the estrogen receptor status, and the genomic, the nuclear grade. And when you total it all up, the higher the score, the worse the prognosis, and a score of 3 or more is considered as high risk. And we have data both from real world and from trials showing us that disease-free survival is dependent on the CPS-EG score in HR-positive patients, and those with a higher score fare much worse. The baseline characteristics coming back to Olympia were very well balanced between both the groups, and 70% had BRCA1 and around 30% had BRCA2 mutations. If we look at the types of chemotherapy, you can see it was equally divided between adjuvant and neoadjuvant, telling us the increasing trend for neoadjuvant approaches that are taking place. 1/4 of patients received platinum in addition. If we look at the first disease cutoff data, which was actually presented 3 years ago, we can see by Andrew Tutt and his colleagues, you can see that the primary endpoint was reached, and there was an 8.8% difference between olaparib and placebo for IDFS with a hazard ratio of 0.58. This was highly statistically significant. And with additional follow-up, this was presented, I think, this year with the data cutoff second endpoint. The hazard ratio was maintained and the difference was 7.3%. What about overall survival? This was not significant at the first data cutoff, but more mature analysis was presented, I think, at ASCO at the ESMO plenary this year. And you can see that there is a statistically significant difference in overall survival of about 3.4% between the two groups. It also, a consistent benefit was seen across all the subgroup analysis, and whether the patients were HR positive or triple negative, they seemed to derive a benefit. With caution, the numbers are smaller in the HR positive group, which makes subgroup analysis a little difficult to analyze. The other subgroups that one can see, is patients with prior platinum also seem to benefit, as did patients with adjuvant and neoadjuvant. More than 70% of patients completed treatment without the need for dose reduction, but I must caution, in clinical practice, we do need to dose reduce in quite a few patients, and almost 25% of patients in the olaparib group had some sort of dose reduction. Most of these were just one dose reduction. 10% of patients discontinued due to adverse events. And this is important to note because this has a very practical implication. And the most common treatment emergent AEs that led to discontinuation were nausea and anemia. So this is a little difficult drug to give, but once you get used to it, you will notice that most of the nausea that happens in the first 4 to 6 weeks, and after that, it's really smooth sailing. What was reassuring to know with Olympia was there were no long-term MDS, AML, and pneumonitis-like side effects, and in fact, the new primary malignancies were halved in the olaparib group compared to the placebo, and this is a little difficult to explain. So anemia was the only grade 3 adverse event occurring in more than 5% of patients, and that's something we need to be careful about and monitor in the clinic. The quality of life seemed to be maintained versus placebo. There was no clinically meaningful change in fatigue, but you can see that during the treatment it was pretty bad, and it normalized after almost 2 years. So these women do complain of fatigue, and that does seem to hamper the daily living. This very often requires a dose reduction. Nausea and vomiting again was short-term and then returned to baseline as it did with the placebo. So in conclusion, this was one of the first studies in a germline BRCA mutated cohort which showed an improvement for patients in the high-risk group in both triple negative and HR positive BRCA mutated cancer. What are my comments on the study population? This was a very young population of 42 to 43 years. Only 1/4 were over 50. 3/4 were BRCA1 mutated, 80% triple negative, no HER2 positive, this was by design. 3/4 were treated with mastectomy, this is interesting to note, and almost half the patients had a bilateral mastectomy. Risk-reducing salpingo-oophorectomy was subsequently done in 60% of the patients, and this seems to be a useful strategy even for breast cancer reduction. The CPS-EG score is unfamiliar to us and to our pathologists, and maybe it's time to start looking at this as well. There are several questions that remain in the current treatment landscape of germline BRCA mutated patients. So those who don't achieve a PAT-CR and are triple negative, are we going to choose between olaparib and CAPE? And we have a lot of data from other studies as well. In patients on neoadjuvant pembrolizumab and those who don't get a PAT-CR, are we going to combine olaparib and pembro? The jury is still out, but remember, olaparib has shown an overall survival benefit, but pembro has not as yet. In high-risk ER-positive patients, am I going to choose olaparib or abemaciclib? And you can't use them together because they have overlapping myelosuppression and you're going to get a disaster in the clinic. So for those patients who can afford each and everything, you would probably do olaparib for a year and then sequence with abemaciclib, because if you remember in the abema data, they had a period of 16 months after completing therapy that they were randomized to abemaciclib. So you do have that window of time. And lastly, and the most relevant and pertinent question to all sitting here is that should all women with breast cancer now be tested for at diagnosis for BRCA1 and 2 alterations? So these are the current NCCN criteria, which are easy to remember. All TNBCs, all ER positives less than or equal to 45. If they are 46, between 46 and 50, you look for second primaries, you look for family history, and the same follows with ER positives more than 51. So with that, I will end my talk. Thank you.